My name is Michael Fraser. I'm a urologist who specialises in penile surgery in Glasgow. A penile implant operation is an operation to put an artificial material, piece of artificial material into the body to replace the erectile functioning of the penis. So what we do in essence is core out or remount the workings of the penis and replace them with some synthetic substance. Now this could be an inflatable implant made of a material called Bioflex, which is worked with a hydraulic system to put fluid into it to gain erection, or it could be a more simple system where we put two semi-rigid or bendy rods into the shaft of the penis. I think there are two types of men. There are those who have tried lots of erectile function treatments that haven't worked particularly well, but who know a bit about implants and come fueled with a bit of internet knowledge. There are then those who've tried treatments to a degree which have failed and really feel they're at the end of their tether because they don't know where to go. So they pose two different sort of problems. One come with a lot of questions that you can supply answers to, but the others you've essentially got to take from ground zero and take them up to the point where they may have to understand there's a semi-serious operation to improve their sexual well-being. I tell them first the good things about having an implant. I never think that starting with the downsides is a positive way of approaching your patients. So what I tell them is that if I put an implant into them, they will achieve a rigid erection that will allow them to have penetrative intercourse. And I tell them that will work every time they try to have intercourse. We tell them how that works, how the operation takes place. So I tell them that it's largely done by a small cut on the underside of the penis where it meets the scrotum. And that's pretty much all that they'll notice afterwards. We do talk about the changes to the erection. We tell them that the head of the penis or the glands doesn't perhaps get as hard as it used to when they were younger and had a natural erection. And we'll tell them that overall they might find that the penis is somewhat shorter than it used to be, but that these are consequent on their erectile dysfunction and necessary parts of having an implant. So once we've done that, we tend to show them an implant. So we'll show them both a semi-rigid implant and we'll show them an inflatable implant, and we'll discuss what might be the best option for that individual patient. When they go home, I tell them a few set points. The first thing I always bring home to them is I tell them what I've done in the surgery, and I tell them usually that I've left their penis partly inflated by leaving fluid in the penile part of the implant. I tell them they'll be a little bit uncomfortable and they'll get a bit of bruising and they'll get some swelling. I tell them also that all they have to do with their penis for the next 2 or 3 weeks until I see them again is use it to pass urine from, and I don't want them fiddling with the apparatus or trying to have any sort of sexual activity until we've met again and decided that's okay. So I think there are two groups of complicated patients. There are those who are complex because of their comorbid conditions, and that would be primarily patients with difficult to control diabetes, patients who are at surgical risk because of cardiovascular disease, or patients who are on immunosuppressants because of transplants. The second group are those who are perhaps slightly unrealistic in their expectations, and whilst they may want an implant and they may be good candidates for an implant, sometimes trying to marry up what's realistic with what they expect can be difficult. What we don't want to do is go ahead with surgery and have a patient who wishes 6 weeks later that was something he hadn't gone through. There are a few patients who do cancel late on. We do try to spend as much time as we can, and I never say that one visit alone to the clinic is enough to make your mind up and to know everything about an implant and what will happen to you. So I see patients on a minimum of 2 occasions, and one of those occasions will be a week before surgery. Some people at that stage will cancel, and it's usually because they're not sure that this is right for them. And I would always say to patients that we can revisit things later on if they want to go back and try other treatments, or if they're just not sure that this is right for them. We always love it when partners come along with the patients. They can always contribute something to the discussion that the men usually are too afraid to ask. However, in my practice, I find a lot of men come alone and like to pass on the level of information that they think is appropriate to their partner. Experience does tell us, however, that the men that come back a few weeks or a few months after surgery with a big smile on their face are the men who've engaged their partners from very early in the process. I think men who don't have an understanding or a helpful partner who's part of this process never do well, because they always fall short of their expectations. And I think the men who don't have a partner similarly provide a difficult group to deal with in knowing what they're going to achieve and what they're going to expect to achieve in the long run. I say to all these guys that you will notice that your penis is different. You will feel your implant, both when it's inflated and when it's deflated. But no one else will know it's there unless they touch your genitals. I tell them that the sensation for you and your partner of having sex should be pretty much as it was back in the good old days when you had a normal erection. You should be able to reach orgasm and climax, ejaculate, if those are things that you could do pre-surgery. I do tell them that sometimes men will get some lower urinary tract symptoms after surgery, but more often than not that's related to having had a catheter in rather than because of the implant itself. So this is a Coloplast Titan implant. So this is a 3-piece inflatable device, and you can see as I hold this up the 3 pieces. So starting in my right hand here, we've got a fluid-filled reservoir. In the middle we've got a pump, which is the patient's lifeline. That's the bit that he needs to know about. And in my left hand are the 2 Bioflex cylinders that go into the shaft of the penis. So essentially you can see this is a closed system, and because it's worked with a pump, it's a simple hydraulic system whereby by pumping the spherical part of the pump, fluid is drawn from the reservoir into the shaft of the penis, like this. And we can see that the cylinders therefore enlarge and expand when that happens. And likewise, when the patient no longer wants an erection, he opens the valve in here by pressing the button here, and he squeezes his penis to make this deflate.
And where do those components go?
So these go into the shaft of the penis. The penis is composed, I tell men, the penis has got 2 cigar-shaped muscular bodies in it, and these go into those having reamed out or bored out the erectile tissue. This little pump lives in the scrotum, usually between and slightly in front of the testicles, and this reservoir lives either in the back of the tummy or sometimes under the muscles on the side of the abdominal wall, depending on individual cases surgically. So this is a semi-rigid implant. So this is a Coloplast Genesis implant, and when we talk about semi-rigid we mean bendy in essence. So these go into the penis, as did the cylinders of the inflatable implant. These can be put in through an incision at the base of the penis, or what we call penoscrotal, or you can put these in through the shaft of the penis by making a cut below the head of the penis and retracting the skin. These have no other components. These fill the shaft of the penis depending on the various length of the penis, and will be bent down for concealment and to allow the patient to pass urine, and they'll be bent upwards to allow the patient to have a firmer erect penis to allow penetration. As a surgeon, one is always concerned about infection in an implant, and infection doesn't usually arise early, but if there's been a lot of bleeding and hematoma formation in the scrotum, that is a risk in the early post-operative period. I do give patients a letter home with them which outlines some of the common complications, and I say to patients that if he feels a lot of scrotal bruising or swelling, pain in the penis, any discharge, then I'd like to see them. I work on the basis that their own GP won't know much about this surgery, the local A&E department won't know much about this type of surgery, so I want them to come back and see me, my specialist nurse, or one of my colleagues, and we give these patients pretty much an open door to return if they perceive that they've got a problem. That often means that we send patients away with reassurance and we're happy, but I'd rather do that than have patients delay and stay at home with their complications. Well, again, infection is always the issue, and in patients who particularly have higher risk, so diabetic patients, patients on immunosuppressants, spinal cord injured patients, people who have indwelling suprapubic or catheters or who self-catheterize, Again, if these patients ever get pain or redness, discomfort, things that change the way they feel about their implant, we've always got to be wary for that. We've got to make the patients aware that that may be a sign of infection. Sometimes infection presents in a far more dramatic fashion, and there can be a bursting force of the implant, which we call erosion. So a cylinder may appear through the head of the penis, it may appear through the urethra. You may even find a bit of the tubing, or the pump will appear through an infected wound in the scrotum. So those things all tend to be fairly obvious. Mechanical failure sometimes happens. I perceive that we see a lot less mechanical failure than we used to. If it does happen, it tends to be the pump that fails. And again, I encourage these patients to come back early to make sure this is not a pseudo failure, something that we can rectify. And if they do need a revision, then we can revise it early to minimise their distress at having no sexual function for a while. I think a penile implant provides an excellent solution to erectile dysfunction for lots of couples. I think it requires a unified couple who both want to go down this route and who understand that this will change their sexual activity and the pattern of their sexual behaviour somewhat. However, it's far more reliable than most of the other treatments they will have tried at some point, and gives them surety and regular intercourse without major surgery to go through. I would always say to patients that it's important to think long and hard about having an implant. Functional surgery is not something that you should rush into. Be careful and be certain that you understand the risks and the benefits, and also make sure that you go to a centre where this is done on a regular basis by surgeons who have a lot of experience in this type of surgery. Your surgeon will be happy to tell you how many of these cases he does in a year, and he'll be able to tell you what his outcomes are and his complications are. And if you're happy with this, then you can go ahead with have a penile implant.